Hello, everyone. My name is Aki Smith, and I'm the founder and executive director of Hope for Stomach Cancer. I want to thank you all for joining us today for GI, ASCO 2022, and ESMO 2021 updates for esophageal, GE junction, and stomach cancer. This year, GI ASCO, which is always hosted in San Francisco, was hybrid. We did have a presence at GI ASCO where our lovely volunteers, Irasima and Brian, managed the booth. Thank you. I am so excited to learn about the latest research, clinical trials, and any other significant findings and how this might apply to our communities. Before then, I quickly wanted to share some of our resources we have available at Hope for Stomach Cancer. If you go to stocan.org, you'll notice our website was recently redesigned. We've added a resource library where you can catch all the webinars we posted. You can also receive a free Hope in the Bag, which is a patient navigational kit. You could join our stage 4 support group with a GI oncologist. Our next one is February 28th at 5 p.m. Pacific Standard Time and 8 p.m. Eastern Standard Time with Dr. Sam Kleppner and Dr. Mike Gibson. You can join our private closed Facebook group, which is stomachcancersupportfb.org. You could stay tuned for more Hope webinars. And as always, please sign up for our newsletters. This will help you be able to see the different events that we're having. Thank you. And now the introductions.
Hello, everyone. Good afternoon. Thank you so much for joining us today. Just some quick housekeeping notes for you before we get started. There are 3 different ways in which you can reach out to us. You can go ahead and use the Q&A box at the bottom of your screen. You can also go ahead and use the chat function and the raise hand function. Feel free to reach out to us. And if you'd like to get more information, you can always visit our website at stocan.org. Thanks again. And now I'd like to go ahead and introduce our presenters today. I first have Dr. Steve Marin. He is a medical oncologist at Memorial Sloan Kettering Cancer Center, who specializes in treating gastrointestinal malignancies with a focus on esophageal and stomach cancers. His research focuses on applying informatics tools to identify novel therapeutic targets and improve patient selection for targeted immunotherapies. A major focus of this work has been improving our understanding of tumor heterogeneity and developing clinical trials aimed at overcoming this barrier. Next, we have Dr. Natalia Uboha, who is a medical oncologist at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. She specializes in gastrointestinal malignancies. On a state level, she is the co-director of Wisconsin Oncology Network, which is a regional network of cancer clinics that aligns community and academic health centers to bring novel cancer treatments to patients in the community. Her clinical interests include gastrointestinal cancers with a particular emphasis on hepatobiliary and gastroesophageal cancers. Thank you so much for joining us, and please take it away.
Hi, everyone. Thanks for having us. Natalia, long time no see since San Francisco at the conference.
Hi, Stephen, and hello, everybody. Thank you all so much for joining and for being part of this discussion. And thank you very much for Hope for Stomach for Cancer for sponsoring and setting up this meeting. We thought it would be helpful for our patients to talk about some of the recent developments that have been presented at recent meetings for upper GI cancers, and provide some information from the trials that were presented both in San Francisco, as Steve has alluded to, but also at the international meeting that was in Europe in September of 2021. We thought that we would start talking about it, just us giving some updates about the recent studies, and pause after each section to make sure that we are addressing all the questions and answer that any questions that may arise. Just to give you a broad outline that Steve and I have came up with, We'll talk about metastatic cancer. We'll talk about immunotherapy in metastatic cancer first, talk about different subtypes in metastatic cancer, HER2 positive, microsatellite stable, gastroesophageal cancer, and some of the recent updates for these particular patients. And then probably move on to some of the studies that are ongoing. And Steve will talk to us about some of the, and I will too, about some of the new drugs and strategies that are on the horizon. Steve, what do you think? Is this a fair summary of how we're going to
I
approach
think
that?
that sounds great. That's a lot to tackle in the next hour.
But we'll stop and of course ask, make sure that all the questions are answered.
Yeah, please, if you have any questions, enter them in the chat box and we'll keep an eye on those, as well as the questions that were submitted prior. So where should we start? Well, what are your thoughts on starting with immunotherapy?
Yeah, immunotherapy has been making a splash in gastroesophageal cancers recently. So we'll talk about metastatic disease first. So in patients who are diagnosed with gastroesophageal, so esophageal, gastric or G junction cancers, we now use immune checkpoint inhibitors or immunotherapy in first-line settings. So in patients who have not been treated with any other modalities prior to the diagnosis of stage 4 disease. And the two drugs that are approved in the United States are nivolumab and pembrolizumab. Nivolumab is approved in combination with chemotherapy for all patients, but we do know that it actually works much better if patients' tumors have PD-L1 expression. And at recent meeting in San Francisco, we have seen some updated analysis from the big study, Checkmate 649, which looked specifically at whether nivolumab benefits all patients or some patients with metastatic gastroesophageal cancer. And so my takeaway from those updated analysis is that nivolumab does help patients with metastatic gastroesophageal cancer, but it really works primarily for those whose tumors have positive expression of the biomarker called PD-L1, in particular PD-L1 score 5 or greater, and CPS stands for combined positive score, which our pathologists all test for it. So at least in my practice, I reserve the use of this drug for patients whose tumors have positive PD-L1 expression, and in particular CPS 5 or greater. What about you, Steve? How do you use that nivolumab in your practice?
Exactly. And so I put a slide up that I want to give credit to Dr. Lordick for showing. There's just such a difference in terms of where we're allowed to use these types of drugs. So whereas in the US, we can basically use this in everyone per the FDA, as you alluded to before, the benefit was really seen in folks with a CPS score of 10 or greater with pembrolizumab, 5 or greater with nivolumab. But I don't think it has anything to do with the difference between the drugs. I think it was really how the studies were designed. And so in my practice, I give the benefit of the doubt, knowing that patients with a higher score are more likely to respond. I will absolutely use it if I can, if it's 5 or greater. And I will often use it if it's even 1 or greater, recognizing the fact that if I biopsy somebody twice, I could see a 1 and I could see a 5. And a lot of it is just how many cells were on that slide. Was it from a liver versus an esophagus? Who was the pathologist that was looking at it? Heck, it might even be, did they get their coffee right before they read the slide? And so I really want to give that benefit of the doubt. Now, what I do worry about is that in the initial studies using immunotherapy alone, the response rates in patients who are CPS 0 or less than 1 were exceedingly low, on the order of about 4 to 7%. And so in those patients, unless there is a compelling reason or a trial combining with some other new agent, I generally don't offer it.
I absolutely agree with what you've said. I think you're bringing up some very complex issues with PD-L1, is that on paper, it sounds like a great way to select who will benefit, but in reality, it has been very challenging to use this biomarker. And so my approach is very similar. Just today, actually, I saw a patient who had a biopsy from the liver. The PD-L1, the score was 10, and the biopsy from the esophagus, the PD-L1 score was 1. And in that particular patient, I am going to go with the use of immunotherapy, because I think when we are not sure, as long as the score is positive, I believe in using this drug. But I think we all agree if there's no PD-L1 expression, there's no benefit to immunotherapy. And immunotherapy does come with risks. And so we should really not be giving it to patients who are unlikely to benefit. What about pembrolizumab? When do you use pembrolizumab or Keytruda in your practice, Stephen?
So truthfully, because I'm generally giving FOLFOX chemotherapy every other week, I generally don't use pembrolizumab with FOLFOX just because it's typically every 3 or every 6 weeks. It's just a little more cumbersome. So not that the drug doesn't work, it's just timing. Sometimes for esophageal cancers, particularly squamous cell esophageal, insurance will make me use pembrolizumab because of what the guidelines say. But recognizing that they're so similar just from different companies, I try to make life a little bit easier on my patients. The only other exception is we now have a new approval we'll talk about in a bit with KEYNOTE-811 in patients who have HER2 positive esophageal gastric cancer. The approval there is specifically for trastuzumab with pembrolizumab and chemotherapy. So in those patients, I'm doing it because, again, I can't get insurance approval as often to use nivolumab instead.
Yeah, my approach is very similar. It's as if we compared notes before, but we actually are in completely different institutions. And my approach is very similar. I like nivolumab because it's easier to combine it with FOLFOX. I have used pembrolizumab for esophageal cancer because of approval and some issues with insurance. But really, pembrolizumab has a completely different cutoff. It had a cutoff of 10 in KEYNOTE-590. I think that the data is confusing, yeah, so I'm sure it's confusing to a lot of other people too. But nivolumab is my go-to. So you briefly mentioned HER2. Maybe we should talk about some of the other biomarkers that we typically test for in patients who are starting on treatment. Maybe you can talk about KEYNOTE-811, Steve, since you mentioned it.
Sure. Well, actually, should we come back to the MSI high piece? I know there's a question about that.
Yeah,
well,
we
here,
can talk about MSI. I guess any other bio. So there's a number of different biomarkers that we need to test for. In
so what are you typically testing for up front? Every patient you see, what do you test for over there?
All of my patients undergo HER2 testing, which is old news, right? We've been testing for HER2 for over a decade now. But recently we have a new study that has actually changed the way we treat these cancers, which is, I think, is amazing because we used to treat them with the same regimen that's been developed over 10 years ago. And this is based on a study with pembrolizumab. This study is still ongoing, actually. And so about 15 to 20% of patients' tumors have these, what I call antennas on the tumor surface called HER2. And so there's drugs that can bind to these antennas and turn off the signaling through these antennas and can help kill off more cancer cells. The drug that we used to use historically for treatment of these HER2 positive cancers was trastuzumab or Herceptin, which is approved also for breast cancer, and we use it in colon cancer as well. And so we've used for over a decade, we've used chemo plus trastuzumab. That's been our gold standard. And when we try to even add another drug to HER2 to this treatment, it has not led to improved outcomes. And so KEYNOTE-811 is a large international study that's ongoing that asked, if we add immunotherapy, can we improve outcomes for these patients? And the study is ongoing, but some of the early results were presented at ASCO and were very much positive in favor of the addition of pembrolizumab. And by positive, I think, Steve, you have the slide. By positive, these are waterfall plots. When we looked for the oncology, we want the bars to go down. We want them to be less than 0. If they're pointing down, that means good. That means the tumors are shrinking. And so it's amazing to see on the left-hand side, that teal graph, that most of the patient's tumors significantly decreased in size. And when you look at this dotted line, I don't know if you can see my mouse, but when you look at the dotted line, thank you, Steve, that means that the tumors have shrunk by at least 30%. And so when pembrolizumab was added to chemotherapy plus trastuzumab, most of the patients, the vast majority of patients, had some shrinkage of the tumors. Now, I think any decrease was 97%, and over close to 75%, close to 2/3, had shrinkage by at least 30%, which is amazing to see, in our field. some patients had benefit from trastuzumab plus chemo as well, but the waterfall plot, if you could see that the pointing down wasn't as impressive. So based on these results, even though we still don't have the final results of the study, this was impressive enough for FDA to approve pembrolizumab for patients who have HER2 positive disease. And so now all our patients who have HER2 positive tumors receive pembrolizumab or Keytruda in addition with chemotherapy and trastuzumab. And I've incorporated into my practice, and regardless of PD-L1 expression, but HER2 is a marker that we are very familiar with. Every patient should get tested for it, and so this has been an easy incorporation. What has your practice changed as well, Steve?
Oh, we ran the phase 2 here, and I put quite a few patients on the phase 3, and it's really remarkable how well people did with adding the immunotherapy to it. The real question now is, in the study, we used the oral version of 5-FU capecitabine, whereas we typically use 5-FU with a 2-day pump in the US just because of toxicity. So I guess the question to bounce back to you then is, are you doing this with FOLFOX or are you doing this with Capox?
I do it with FOLFOX, with the standard chemotherapy that I use. A lot of my patients can't swallow pills because they come in with tumors that cause problems with swallowing, and so I use FOLFOX. It is a bit cumbersome, as you alluded to earlier, because Keytruda is given or pembrolizumab every 6 weeks, chemo every 2 weeks, but we can manage. I think these types of results are worth going forward with this regimen. I think this is absolutely.
It's really fantastic, just how long people can be on this, and a 20% increase in the response rate there. It's really phenomenal. And so it's nice to have this additional option for our patients.
What other biomarkers? Maybe you can talk a little bit about microsatellite unstable gastroesophageal.
Yeah, let me go back a couple of slides, because I saw Bart had a great question as well. Going back to the immunotherapy for 1 second, there's something we didn't touch upon. So all of these studies that we had mentioned before were actually patients with stage 4 or metastatic disease for integration of immunotherapy with chemotherapy as their first type of treatment. What we didn't talk about is that there are 2 other areas where we have approvals for immunotherapy as well. One is for patients who have microsatellite instability, and there's actually an approval for using this in the second line, though now people are usually getting it as first line anyways with these newer approvals. But what microsatellite instability is basically a defect in the proofreading system of the DNA, such that you incorporate quite a few different mutations. And some of these mutations on the tumor can actually be recognized by the immune system if you just tell the immune system to turn on a bit more by taking the brakes off with these immunotherapies. And these patients in almost any trial you'll look at will have a response rate where it's shrinking down by that at least 30% that Dr. Ubo had mentioned. So at least 60% response rate, sometimes even higher if you use multiple immunotherapies together. And these are really remarkable numbers that get us quite excited. And the population that has this, I would say, is on the order of about 7% of patients with esophagogastric cancer, primarily with gastric cancer. And so one question that Bart had asked in the chat was, is this type of therapy only for those with metastatic disease? And the answer is actually no. So there's an approval now based on Checkmate 577 for using nivolumab in patients with esophageal cancer who had chemotherapy with radiation followed by surgery. And again, going back to that difference between Europe and the US, the approval is regardless of that PD-L1 expression. And this included patients with both squamous cell carcinoma of the esophagus, as well as adenocarcinoma, with the adenocarcinoma behaving quite a bit like stomach cancer. Functionally, if we look at the genetics of it, if we look at it under the microscope, these adenocarcinomas of the distal esophagus and the stomach, they look the same. And so that's why you'll keep hearing us saying gastroesophageal or esophagogastric. Functionally, we see them as one cancer, we treat them as one cancer. And so we now use this after surgery in the patients who had chemoradiation. There are many, many trials going on now combining chemotherapy with immunotherapy in patients with stomach cancer. But now there's also a brand new report of a study Don't ask me to pronounce this. I think it's neon ipica, based on the fact that it was nivolumab with ipilimumab. But this was a French study that actually looked in MSI high patients, those patients with a very high likelihood of response, who received 6 cycles of the ipilimumab and nivolumab in the local setting, so where they only had disease confined to the stomach and esophagus, and then went on to receive surgery, followed by nivolumab for 9 months after surgery. And they basically saw that 59% of the patients who had just these 12 weeks of therapy before surgery had no disease present upon surgery. So again, everything comes down to about 60% of this population, but a really remarkable response that asks the question now, in this small group of patients, do they even necessarily need surgery? And larger studies and longer follow-up from the study will help answer that question.
I honestly still think this was the most impressive study from San Francisco in upper GI tumors. We saw, not that other studies are not impressive, it's just they were more updates on the studies that we've seen some early results from. But this was incredible to see. I think this speaks to the fact that biology and molecular underpinning of the tumor really matters. I think it tells us that we definitely need to continue to characterize the tumors on a molecular level. Biomarker testing is important. It is not just an academic exercise. We can actually alter our treatments and really alter patients' courses based on the information we receive. In my practice, we check all patients with gastrointestinal cancers, regardless of the stage, have tumors that undergo testing for microsatellite instability, which is a quick test. Pathologists can do this test in any lab. It takes about 24 to 48 hours to get the results. I know that in community practices, it's not as widely adopted yet in early stages, in particular for gastroesophageal cancers. I think every patient has colon cancer get these tests, but this study in particular tells us that we need to keep testing. We need to look at what particular alterations are present in patients' tumors, because to see these types of results was incredible. I think you mentioned that 60% of patients who went to tumors had no tumors left at the time of surgery. I think it's too early for us to know whether surgery can be omitted, because these patients have only been followed for about 12 months, I think. So we need more and more data, and I think there will be more studies, but again, incredible results without chemotherapy. I think
it's really exciting.
Yeah,
it's really exciting, and this will do a lot of good for our patients. While we're talking about MSI, there's one more thing we should mention. I know somebody had asked a question about MSI. For patients who have microsatellite instability, there are 2 ways of getting it. One way is that a protein is actually silenced, and that's how you lose your proofreading. But the other one can actually be genetic. You could inherit this from family members. And so it's important, if you do have an MSI high or microsatellite unstable cancer, it's important to ask your doctor if you've had germline testing, that is to rule out something called Lynch syndrome, which could have implications for other family members who may require additional screening. Very important. But I digressed. I hope I addressed your question there, Bart, but there are some other exciting developments in the HER2 space that we're going to talk about. Natalia, how do you like to explain antibody drug conjugates?
So this is a new class of drugs that's entering the market. It's already entered the market. So what I say about these drugs is basically it has 2 different pieces to this drug. It's a drug that has it has a piece that's an antibody, which I call a hook. I tell patients it has a hook or an antibody that helps this drug to attach to the cancer cells. And then another part of the drug is actually chemotherapy. So these drugs are chemo drugs. They have side effects that are similar to chemotherapy. However, they're much more targeted. These drugs have a way to deliver chemotherapy to where it should go rather than everywhere. I think I'm probably being too positive and simplifying things, but that's the idea. And so what this drug is, trastuzumab deruxtecan, or in HER2, this drug has 2 different pieces. It has an antibody that's very similar to trastuzumab, or it binds to the same place where trastuzumab binds on HER2. And then another piece of it is a chemo portion, or a chemo. They call them payload. So it delivers this chemo bomb to the tumor cells. And so this drug is now approved in the United States, but it was initially studied in Asian countries for patients who had HER2 positive gastric cancer. Again, we're going back to HER2 positive gastric cancers who have had at least a couple different prior treatments. And these patients received this drug versus some other patients, like 33% of patients receive chemotherapy. And so this drug is given intravenously every 3 weeks. And again, this drug did much better than chemo in patients who had tumors that had HER2 positivity. So based on these results, which were initially presented a year ago, FDA approved this drug in the US, but we also now have the results from the study was performed in Western countries as well. And the study was presented in France, asthma meeting earlier in the fall, that this drug works in Western patients as well. And the reason I'm bringing up Western versus Asian patients is because the biology of the tumor is very different depending on where patients live. Patients who develop these tumors in US or in Europe have a somewhat different biology of these cancers compared to Asian countries. And so I think it's important to confirm the results that we see in Asian studies with results with studies that are done in Western countries. And so this drug again is now approved. It's approved in patients who have received one prior treatment, so usually treatment with trastuzumab and chemotherapy, enough Keytruda in first line. And it's shown that the tumors shrink pretty significantly with this drug, and this drug leads to patients living longer. The issue with this drug that we need to keep in mind, again, that this is a chemo drug, and so it does have chemo-like toxicities. And so we have to be mindful of that, especially in patients who have had 1 or 2 different prior chemotherapies. The drug may be difficult to tolerate. It can cause nausea, it can cause low blood counts. We as oncologists are very familiar with these side effects and can help and know how to manage them, but something to be mindful of. The other issue with this drug is that this drug can cause inflammation in the lungs. And this is, again, something that we are learning how to manage. Again, the inflammation in the lung is called pneumonitis. We have managed pneumonitis from immunotherapy, other drugs in the past, and we are familiar with this. But in patients who have had 1 or 2 prior lines of treatment, if they develop significant pneumonitis, this could really affect the quality of life. And so we have to be mindful of that and be aware of that as a potential side effect. I do use this drug in my practice. In my practice, what I make sure I do is I make sure that patients' tumors still have HER2 antennas, those antennas after they've been on trastuzumab. Because we know that tumor cells have a way to really outsmart chemo, and about 30% of tumor cells can lose those antennas. And if they lose the antennas before you give patients this drug and HER2, then this drug is not going to work as well. And so I make a point to either look at liquid biopsies, and I think Steve will talk about what I mean by liquid biopsies in the next section, or I make sure to rebiopsy the tumors to make sure that we know what we are still facing, what kind of tumor we're dealing with. I was wondering whether you have any comments on that after I just talked for 5 minutes straight, Steve.
You were on a roll. I mean, as you were alluding to, I do liquid biopsies just because I like the non-invasive approach. But what I find is that the previous therapy of combining immunotherapy with trastuzumab is just so effective that people generally have a little bit of progression, usually like one lesion that just popped up with a resistance mechanism. And they often don't have enough to even detect anything in the circulating tumor DNA, that liquid biopsy. And so I worry that absence of tumor DNA doesn't actually mean that they're no longer HER2 positive. It might just be that they don't have much disease, which is actually a wonderful thing. And so it is often important to do that rebiopsy, since about 1/3 of patients do lose their HER2 positivity. But the other piece that I found really remarkable about this study are these exploratory cohorts here. And so there's a question, and I see for Anonymous there, we'll certainly get to other HER2 negative approaches, but keep in mind, these patients over here in this exploratory cohort are actually technically HER2 negative or HER2 low is what we call them now. And this drug was actually really effective even in these patients. It's about a 25% chance of having a really deep response in these folks, which is pretty good for something that you give once every 3 weeks without a pump to go home with. So I think there will be room for some more patients as well, in addition to the ones that we usually consider HER2 positive.
And there's a
But
question in the chat about, I think you tried to address the HER2 negative, PD-L1 negative, and I think that that is a very good question. You're right. We are concentrating on the biomarkers that we know about, and that I had that conversation with some of my research partners just a couple of days ago. Where are the unmet needs? Where do we need to work more? And I think this is the patient population where who are PD-L1 negative, immunotherapy doesn't work. HER2 negative, anti HER2 drugs do not work, and so I think there are other biomarkers and there are other drugs in development that are entering the market, like such as FGFR2 or Claudin antibodies. I know, Steve, you did not know what I was going to say, so you put in a different slide on, but we can go back to this. But just to answer that, and we can talk about it in maybe in a little bit, but there are other markers that we will be testing the patient tumors for that we can touch upon. But I think Steve is he's been very excited about this. So
many different directions we can go in here, because I'm looking at Ali's question there in terms of a negative ctDNA result. What does it mean? And Bart clarifying, when do we do chemotherapy versus immunotherapy? Okay, which direction to go in next?
So I wonder whether, since we mentioned liquid biopsy a few times, Steve, already, maybe we can just explain what we mean by that and how you use it in practice.
Sure. So in my practice, what I do for all of my patients, basically all of my patients, but especially all of my patients with stage 4 metastatic disease, is I do genetic testing. And I do other molecular testing just from the get-go. So the initial tests I do are the HER2 that we talked about, PD-L1, microsatellite instability, also EBV testing, similar to MSI, very high likelihood of response to immunotherapy, represents about 5 to 6% of the population. And then the last piece is the genetic testing I do. I'm at Sloan Kettering, so we have our own panel called MSK Impact that now has about 500 different genes that we're looking for. And when you do a tissue sequencing test like that, it takes several weeks to come back. Ours actually takes 4 weeks. You use Foundation up there, Natalia, or what do you use?
I use Strata Oncology and I use Garden for Liquid.
Okay. So for tissue testing, it'll take somewhere between 2 and 4 weeks. And so one other thing that we do is rather than looking at just a single site, we take some blood, something we call liquid biopsy now. Sounds like we both use something called Guardant 360, but there are other companies that do it as well. And that turns around in about 7 to 10 days with a panel that's about 80 genes now. And it gives us sort of this preview of, from all sites, when you average all the tumor DNA that's in the bloodstream, what are you finding? Is there anything targetable? Can you find that needle in a haystack where you can identify a drug that you can add, preferably on a clinical trial, or if there's an approved drug? Or is there something that you can file away in your back pocket to use should therapy stop working, to really help guide you in which direction you should go next? And so I find this very helpful to use the tissue and the liquid biopsies in conjunction. Now, there's a question from Ali in terms of how reliable is a negative ctDNA result. Oh, we could talk about that for hours. That might be for a different venue. The reality of it is people don't really know yet when to use what. And it's actually been an issue in a lot of clinical trials where they try to start with ctDNA to screen for patients and realize they're missing a lot of patients. And so for some of these upcoming trials, they're actually saying they'll start with the ctDNA. And if they don't find anything there, they actually then go to tissue, recognizing that it takes a little bit longer sometimes.
But I want to clarify, because when we're looking at this particular slide, I think ctDNA here is referring to minimal residual disease, what we call MRD assays. So there are ways, there's 2 different liquid tests that we can use. One of them is a test that's kind of faster, I don't want to say cheaper because I don't think it's cheaper, but a faster version to find out what mutations are present in the tumor. And if that test is positive, then we can go with it, right? If it's positive, we have HER2 amplification, or we find something else, then we can just go after it, as Steve has said. If it's negative, then you don't know, maybe the tumor is not producing DNA, maybe the test was not really good. So that the negative is not always reliable. So that's one test, that's Guardant. Another test that we use in our practice is to look for minimal residual disease. And we are just learning how to use this test for gastric cancers and esophageal cancers. And that's basically to say, if somebody had treatment with curative intent and they had radiation, or they had chemo, they had surgery, when the tumor is out, can we still detect any residual tumor DNA in the blood? Because we know in colon cancer, if you can detect that, that means there's cancer hiding somewhere. We just can't see it with scans. And so we started to use that different test now in esophageal cancers as well to look for, sometimes it can tell us that the tumor is hiding. We can pick up recurrences. I just picked up, unfortunately, recurrence earlier in my patient who was receiving immunotherapy after surgery, and we realized that the tumor has come back. But it's hopefully in the future, we'll also be able to use this test to tell us, we don't need that long of an immunotherapy treatment after surgery. You cured already. Or we could say, oh, the test is still positive. We need to add another drug. So that's the hope. This is another way for us to monitor how tumors behaving in different settings. CT scan, as I tell my patients, the CT scan is a black and white picture, and it has to be, something has to be at least half a centimeter to a centimeter in size by the time you see it. So you potentially are missing this critical window where you can still see just a few tumor cells that hopefully we'll be able to eradicate. We're not there yet, but I'm super excited about this technology as a way to add to how we can tackle the tumors and how we can monitor responses to therapy.
It's actually one of the most exciting pieces of data in colorectal cancer that was presented last week in San Francisco, where you can use even more sensitive tests, in this case, an assay called Signatera, where they're actually taking the tumor and doing a really deep sequencing and coming up with a personalized ctDNA assay to measure in the blood, looking at usually about 10-ish different mutations that they're finding in the tumor, and then serially seeing if they could find those before surgery, after the chemotherapy that some people get after surgery. And the idea is that when people have this present in the bloodstream, and as you can see in the slide here, quite a few more patients who have this detectable ctDNA floating around their blood go on to recur, versus only a very small fraction of those where it's not detectable. And so on one hand, you could say, well, maybe we should be escalating the therapy that we give to patients where this is detectable. And maybe we can de-escalate therapy or not give therapy after surgery in patients where this is not detectable and save them all this toxicity potentially. And so we have many different ways to potentially use a test like this, but these trials are still underway. So we're really excited to see the ways in which we can use this approach to help our patients. But I'm seeing many more questions about vaccines. Okay, so let's jump to some of these newer approaches here. So we talked about the antibody drug conjugates, we talked about targeted therapy, we talked about immunotherapy. Okay, so how about moving on to not vaccines yet, but how about modifying the immune cells to see what we can do with those? So people may have heard the term CAR T, and the idea of a CAR T is that you're taking an antigen receptor on the T cell and you're literally rearranging the receptor such that it's able to then recognize and kill the tumor cells and then really mount an immune response to help clear the tumor cells. And so we're starting now to see studies like this in solid tumors, including esophagogastric cancer. And so this is a study that's actually underway at the University of Pennsylvania, where they're modifying macrophages to then target these HER2 positive cells. And I'm really just using this as a schema to demonstrate how labor intensive it is for these types of therapies, where you give the patient a drug to help increase their white blood cell counts. You then do apheresis, where it's sort of like dialysis, but filtering off these white blood cells. You then select these very specific subsets of cells that you're looking for, these CD14 positive, which is one of those proteins, those hooks on the outside of the cells. And then you try to mature them. And then you take this very special viral vector to then try to force the specific receptor that you're looking for into the DNA of these immune cells. And you freeze them down, you send it back to the hospital, and you infuse the patient with these cells. So it's a very laborious, a very expensive process with the hope that you're going to then give them these reactivated, retrained immune cells to help wake up the immune system and clear the tumor without any chemotherapy. What did I miss?
Steve, can I ask a question about this? I know you're
Please.
super, you tried to put the slide on 3 times now, so you're finally talking about it. The idea is that you go through all of these laborious processes, but the idea is you give one infusion, maybe two, correct? And you're hoping to really achieve really good responses with one infusion. That's my understanding. As opposed to chemotherapy, immunotherapy, we'll have to come in every 2 weeks, and this is kind of ongoing treatment. Here, you go through all of this intense work, infuse these cells that are supposed to do all the work for you. I think that's the hope, and you don't have to come back. Am I understanding this correctly?
I wish that were the case. And there are two ways in which this type of approach fails. And one is you're making that assumption that all of these cells are HER2 positive and have the target that these macrophages are trained to go after. And so if not all of them have it, you'll select for those that don't have it. The second issue is that you're relying on these cells to self-propagate, to replicate, to grow, to expand, and to persist. And what they find with a lot of these products is that you can see an increase in these for 1 month, 2 months, 3 months, 4 months, and then you just see it dropping off over time. They don't persist, in which case sometimes you have to go and do it again.
Mm-hmm.
And
Right.
typically when you're doing this, you're admitting people to the hospital and you're giving them pretty aggressive chemotherapy to wipe out the white blood cells to help favor these ones that you're giving them. And so it's a high risk, high reward type approach that sometimes might require repeat infusions.
But the technology is not new. And so these types of the CAR T cells and modified cells are already used pretty widely by our hematology colleagues, where it's approved for the treatment of leukemias, lymphomas, which is great for us, or at least for me. We are right now opening our first CAR T cell therapy trial at UW, and we'll be working jointly with our hematology group to help us manage the side effects and help us manage, the chemotherapy before. I think I am super excited about this new way to target cancers. I think this will open many doors, hopefully, as long as we can identify the right targets and learn how to modify cells. And I agree with Steve. It's a lot of work, it's a high risk, but hopefully a high reward proposition. So I am glad that we are moving these types of new technologies into the solid tumor world. I've decided I'll end it on a more positive note, this section.
It's exciting. So, just to sort of mention a few different studies that are either open or opening in this space. And this is a few of, I don't even know how many dozens. I'm sure you have a handful more if you want to mention any. But there's one drug called ZW25 or zanidatamab. They're opening a phase 3 study that's going to be CAPOX with zanidatamab, which is sort of like we haven't discussed, a bispecific antibody. We have one arm that's Herceptin, one arm that's pertuzumab, or Perjeta is the other name of it, used in breast cancer. So it attacks the HER2 in 2 ways. And then they're adding a different PD-1 inhibitor called tislelizumab. There's Mountaineer, which is after people have already had trastuzumab, doing RAM plus Taxol, so our typical second-line treatment, plus the trastuzumab, plus another drug called tucatinib that's been very successful in breast and now colon cancer. And then the third one that I have on here is that CAR T study that I mentioned before. What else do you have on the list there? I'm sure you have some fun new agents too.
There's a lot of drugs in development for going after HER2, just because it's such a known target, but nothing as far along. We have study from the company called Dragonfly Therapeutics, where part of the antibody binds HER2 and other antibody binds the receptor on immune cells. There's a lot of drugs in that space, but I think there was a good question in the chat, and I tried to answer it typing. But I think the question is, what do we do with patients who don't have HER2 receptors and PD-L1? I maybe Steve would be good. Maybe you can comment on some of the other targets like FGFR2 and Claudin, just to mention them, because we are slowly chipping away at some of the other that subgroup that doesn't have PD-L1 or HER2, and hopefully we'll be able to offer some what we call targeted or specific therapy to all patients with gastroesophageal cancers.
Sure. Why don't we start with Claudin? So when we talk about genes and proteins, you have genes that are basically encoding a protein. And sometimes you can have different forms of the same protein that just are sort of cut and put together in different ways. And so Claudin 18.2 is a slightly different protein that is found in many patients with esophageal and gastric cancers. And the reason you go after something like this is you want those unusual proteins that are found more on cancers than on normal cells, because then you don't get as much toxicity. And so there have been trials that have been targeting this for probably about 7 years now, that are now in phase 3 studies with some newer agents coming as well. And so the one that's been around longest is zolbetuximab by Astellas, and we'll hopefully have results from that soon. More recently, there are some newer agents, one called TST-001 that they're doing with or without immunotherapy. That's supposed to activate the immune system even more. And then, yeah, I thought I had a slide in there. Similarly to what I just showed you with HER2, there was data presented at ESMO in the fall with CT-041, which is a CAR T product. So where they're modifying that chimeric antigen receptor of the T cells as opposed to the macrophages, and then infusing patients back with their primed cells. All with the idea that if you target this protein, you could help kill the cancer. And most of these patients are actually HER2 negative. And what I'm actually most excited about is that about half of the patients in the data that was presented so far for the CAR T trial, about half of them have diffuse type or signet ring cancers, cancers that we find are generally less responsive to chemotherapy and targeted therapy and immunotherapy. And so this is a nice option for those people who don't have these kinds of markers. So I think these will be interesting strategies to watch. Are there any agents that you have over there that you're excited about with Claudin 18.2?
No, we are in the process of opening a phase 1 study with another anti-Claudin. I've had a few companies have reached out to us going after that target for both gastroesophageal and pancreas cancer. So I'm hoping that means something, but I'm being cautiously optimistic. We'll have to see. I mean, this is an interesting target. What it does, it's present outside of the cancer cells, and it just organizes cells. And when it's overexpressed, the cells are just kind of ugly and don't look normal and kind of become more distorted, which is why this protein is dysregulated in cancer cells. I think there's a question about the other target, DKN01 or DKK1, which is another target that's earlier in development. We've known about this target for a shorter period of time than Claudin. Claudin has been in development for a long time. It just took a long, it's taken a long time to get the results of the first study. DKN01, I think we just learned about in the last few years. And this is a molecule that, again, can affect what we call tumor microenvironment and immune cells that are present near the tumor. And the idea behind this molecule is that maybe it can help, and I'm oversimplifying here, but maybe it can help when used in combination with immunotherapy, can help increase the activity of immunotherapy against these cancer cells. The study, and we have the study, the Stinger study open at UW, and I don't know whether you have it open at your Memorial, Steve, but the studies are ongoing. They're very early on. But the results that were presented thus far, and we did not enroll patients to that part, but the results that were presented thus far were pretty interesting. The results presented of chemotherapy plus immunotherapy plus the drug that goes like DKN01 in patients who have not received any treatment showed that basically none of the patients that were in the study had tumors that grew. But the study was small. I don't remember, I think 20 to 30 patients. I don't know whether you remember, Steve. I didn't look at this. It was a relatively small study. And so it definitely needs validation. We know that there are some patients, and again, particular other antennas that they're going for in this study potentially benefit more. I think definitely a target worth examining further. It's present in about probably 20 to 30% of patients. It's not going to be present in a lot of patients, but the data is early. We have the study going. I'm again cautiously optimistic, worth learning more, but not ready for prime time yet. Steve, I was wondering whether you have anything to say about this particular study.
No, each study is so different. They're each using a different antibody. Everyone says theirs is the best. And what's interesting is that it's sort of an arbitrary cutoff that they're using. And so some companies are able to work with a very low amount of the protein, which is one of the hopes of the CAR T, as well as with the second one listed here. You just might not need as much, so then it becomes a larger population that's eligible. So it's just always nice when we have new options.
I think it's important to mention bemarituzumab as well, FGFR2, which is again another target that we may be going for in this patient population. That the study was a phase 2 study that was, the initial results were presented a year ago in San Francisco on patients who have not received any prior treatment, were given either chemotherapy or chemotherapy plus the drug called bemarituzumab, BEMA. I can't pronounce all of these words either. And for patients to qualify for participation, again, they had to have an antenna, FGFR2, and they had, the patients that were eligible had no HER2, but they had to have FGFR2. So again, we're trying to carve out another slice of all patients with gastric cancer have a different biomarker. And the study was positive in favor of bemarituzumab, especially for patients who had a lot of FGFR2. In fact, I think it close to double how long people live with the addition of this drug, but the studies were relatively small and need confirmation. So I think we are discovering more and more different biomarkers or different antennas that are present on cancer cells or near the cancer cells, which is great. I think we will have to figure out how to use them, how to test for them. Should we be combining them? So that's, I think it's a good problem to have. We finally have leads after a few years of negative studies, but there's a lot of work ahead of us.
Completely agree. And so the follow-up to this actually should be opening around the country in about the next month or two. And so based on those phase 2 results, we're really excited for this to open. Chemotherapy with immunotherapy, then with or without this bemarituzumab. But I do wish they chose an easier name.
Yeah.
And then let's see, one other target actually, just wanted to bring up, so I see there are a couple comments in terms of viruses and other immunotherapies. So I want to talk about one other target called MAGE-A4. It's another one that's actually pretty uncommon. And it's uncommon because it requires that you have a certain protein on your blood cells, as well as a certain protein called a cancer testis antigen, in this case, MAGE-A4, that's on the tumor cells. And so we see it somewhere between about 5 to 10% of patients that have this. And so there are 2 different drugs in the clinic that are both very interesting drugs in their design. So you have one, which is the phase 1 of this immunocore drug, IMCC103C. And some data was presented actually back in December showing responses in ovarian cancer and head and neck cancer. And this is another one of those bispecifics where you have one arm that's going against the MAGE-A4, one arm against CD3 on the T cells. And the idea is that you're bringing those T cells into the tumor to then help kill the tumor. This is with or without immunotherapy. And so again, it's that really complicated design where you're collecting the blood from the patient, you're introducing a virus into these immune cells to help introduce what you're looking for there and then re-injecting into the patient. And, excuse me, this is the other agent. I have my title wrong, excuse me. This is actually with that second agent here, the SURPASS with Adaptimmune, where they were able to demonstrate that patients with esophagogastric cancer, many of them actually had really nice responses. You could see in this plot here with everything shrinking down, and some of them very durably. So here we're looking 40 weeks out that the patient's still doing well. And so with this, really, we now have several different targets that we've gone over in the last 50 minutes, where we couldn't really talk about any of this about a year or 2 ago. And so the clinic is full of new trials now that everyone is hopefully coming out of 2 years of COVID-19, more trials opening, more opportunities to really help our patients.
Yeah, I think there's a number of big, first of all, a number of key trials that are ongoing that will change practice. I think some of those are, can we add immunotherapy to chemo in patients who have resectable gastric cancer? We now use immunotherapy for patients who have esophageal cancer, had radiation. The question is, for patients who have stomach cancer, gastric cancer, where we give chemotherapy called FLOT, can we improve outcomes when we add immunotherapy? And those trials are ongoing. Another big trial that's ongoing is the trial that is asking, can we add immunotherapy even with radiation for patients who have esophageal cancer is resectable? Will that improve? Or should we just only use immunotherapy after surgery? That's a big NCI trial that's ongoing as well. So these are, I think, are big trials that have a potential to change practice. But there are a number of still remaining questions that we have to answer. For example, patients who had immunotherapy after surgery, should we be giving them immunotherapy with chemotherapy if the cancer recurs? We don't know. And those two questions were being answered at the same time. And so the studies did not allow prior immunotherapy when they used immunotherapy with chemo in stage 4 cancer. So that's a big question. I think another big question, can we still derive any benefit from immunotherapy in patients who have had chemotherapy and immunotherapy, stayed on it for a period of time, but then cancer started to grow? Should we be continuing, and can we combine it with something else? Or should we say no more immunotherapy, period? And those are the questions that hopefully will be answered as well as like, what is the right partner for immunotherapy after chemotherapy stops working? I think there's a lot of unanswered questions, but I personally feel optimistic that we have a lot more tools out there, a lot more drugs in development that I'm hopeful will be able to help us answer these questions and improve how our patients are doing. I think we are coming to the end of the hour. I'm looking at the questions and
let's see, what haven't we addressed?
I think we've addressed most of them. It probably would be easy if people could just unmute and ask them live, but I think there's a question about BRCA2 and PD-L1. Yeah, I think there's studies with PARP, what we call PARP inhibitors in esophageal cancer. The results have been mixed. I don't usually go after BRCA as a target in esophageal cancer outside of clinical trial in my patients. And I have seen those mutations, I don't want to say not infrequently, but I've seen it in a number of different patients. I always send patients with BRCA mutations for what we call germline testing to make sure that doesn't run in the family. But honestly, in my experience, this was not something that ran in the family. It was a mutation that showed up in the cancer. And if that mutation is present, what that tells me that we should use the drugs like oxaliplatin or platinum agents to go after those cancers.
There is one abstract. I know the paper's going to be out shortly. It came from University of Miami. If you look in pancreatic cancer, I'll post it in the chat for you.
And then I guess the other, there's targets that I've seen less and less frequently. We didn't mention. Steve put together this big international review of the target called EGFR. We all occasionally see patients who have a lot of antennas called EGFR on the surface, and we've all pulled our data together. It was international collaboration that Steve has led to show that even when there's not a big trial, if we put all of our experiences together, we know that these patients can benefit from other targeted drugs. Thank you, Steve.
Well, it's great that we can get everyone together for something like that and hopefully get it added to the guidelines based upon our findings.
Well, I would like to thank everybody for joining us today and for asking these great questions. Thank you all.